Good evening. We are excited for another XPC talk, this time with Evan, who will talk about community health centers and value-based payments. So Evan, I'll hand it off to you and tell us a bit about yourself, and then we can jump into the topic. And just for context, this topic was recently came up because we decided to read your article and found it fascinating and wanted to have you double click on a lot of the interesting topics.
Yeah, I mean, thank you so much for having me, all the folks from XPC, and then also people decided to show up at 8 p.m. That's, as you mentioned, really heroic. I was debating whether to show up or not, and so I made it. So if I can make it, it's amazing that other people make it. Yeah, so a little bit about this kind of project. So as Paul mentioned, I wrote an article about community health centers and value-based payments. I feel like it's a topic that's, I feel like value-based care is always one of those things over the past few years that I kind of know, or like you say value-based care in a way that's just like, oh, value-based care, and just like fixes everything with value, payments and things like that. But I really kind of decided to kind of focus on what this truly means. In general, been working on a project called How Healthcare Works. I've been working in healthcare since about 2016. Back in college is when I started. Started out Harvard Medical School and Boston Children's Hospital, kind of as a data scientist, researcher. I just kind of focused a lot over the past few years on healthcare and Medicaid specifically. And I've always still been confused about how things are connected in healthcare. I remember having conversations with Bryce about PBMs, and they make a lot of sense, but I'm not sure how PBMs work with community health centers or how they work with this or that. And so I've been building a project, which I'll kind of show briefly, about kind of mapping out everything with the friction points. And so this kind of segment I've been working on is on, as we talk about, value-based payments in community health centers. And here's a little view of what it currently looks like. Again, it's just like mapping every little thing. And so it's fun, and it's been a really great learning experience. So a little background on community health centers. I'm assuming that a lot of the folks on this call understands community health centers at like a one-on-one level. For folks who don't, I have information. We can also put that for any of the folks watching this recording on the YouTube description and things like that. But I'm going to assume they have kind of a one-on-one background. So why are community health centers well positioned to do things such as value-based care? So they are, community health centers serve all patients, kind of patients who have Medicaid, uninsured patients, and a little bit of Medicare patients as well. They're really kind of designed around that patient population, folks who, vulnerable, kind of struggling to make ends meet, or just generally are on Medicaid and don't have a lot of other options where providers can accept their insurance. And so they can support things such as, case management, interpretation. They're going to have bilingual staff or just other staff that's able to communicate to patients in a way that other providers, other primary care providers may not. I saw a study that was, I forgot the exact number, but put in the article that community health centers lower the total cost of care comparative to other primary care providers. And I thought that was really interesting that when designed, a center around patients that kind of fit this description, that is seen to have benefits on reducing the cost of care. Probably describes everything from here. And so I had this kind of misinterpretation, if you would, of value-based payments originally. I feel like what I've learned while researching this for 4 kind of solid weeks is that the primary goal of value-based payments is predictable income and to redirect incentives from volume to value. I originally thought it was just a way to get, not just a way to get more money, but a way to get more money as the primary goal. there is ways to do that, I think, which we'll kind of dive into. But really, it's just about saying, allowing community health centers to better plan out their finances for like the year and kind of incorporate how that fits in with the operations. And so if you're potentially kind of making more hires and knowing that you have a PMPM consistently over this next year, from my research, that's what is most attractive to community health centers, is that kind of predictability. And this value-based payments, I guess, also kind of addresses like issues of the PPS system, which I think COVID-19 really kind of highlighted why this kind of payment system, which relies more on volume and person visits, is not the best system. And I think that it's definitely a better system like fee for service. But what I've researched and what I found is that a value-based payment model can allow for staff to be hired that wouldn't necessarily be able to be covered through a PPS. And that can mean like care coordination, that can mean seeing patients not in a clinic setting. And so it's just more of a quote unquote holistic kind of whole person care model to ensure really that they're greater expanding their thesis, or like they're drilling down more on their thesis, which is, to care for the patients. And so that's kind of what I found of why they would want value-based payments. So there are different models with value-based payments, which we'll go into the next slide. Briefly want to cover the idea of downside risk. And so I think folks kind of understand this concept. I'll briefly mention it, that when a community health center works with an MCO, for example, and they set a baseline, and if they, go beyond it, or, go beyond it in terms of they spend less of that PMPM, they get to save that money. Now, if you go above that baseline, you have to then pay the MCO money because you didn't meet your quality metrics, you didn't meet the total cost of care, et cetera. I say this kind of particularly because this is the kind of the way that I found that you can get more revenue because you're taking on that more risk. And so it's like a little bit more attractive to do that instead of upside, where it's like you're not really getting, all that risk because you don't have to kind of cover those expenses, the losses, I would say. You have to eat the losses. But from my understanding, the downside risk, that is a bit more riskier. But again, ideally, there is a better upside in terms of getting more revenue. I think the thing that's really challenging with this is that there's such little margin at community health centers that if you really don't make it, in terms of if you have to pay back money or if you have to eat costs, that could just mean like the community health center could just like lay off staff and like really kind of scary stuff. I mean, it's not like completely shutting down the center potentially, but it's not really not ideal. And so I think health centers are very cautious and apprehensive towards doing things like this. And we'll kind of talk about how to potentially alleviate some of these problems and how they're kind of thinking about this. So kind of 4 different models. I won't go too deep into them, but as mentioned, PPS, shared savings, bundle payments, and the full capitation with downside risk. Something to note, I think we briefly touched upon this at the retreat, that in a risk model, community health centers should be doing this in partnership with an ACO or an IPA. And so I think legally, I'm not a lawyer, so not like that versed in all this by myself, please. But I think that they technically might be able to take on risk as a single entity, but I think the much safer way, and I think they're potentially the more legal way, or not say more legal, but like, I think that like ultimately what I've heard, at least, I'll just kind of go and kind of say this, is that the better way to do this is to kind of have community health centers be an ACO or an IPA, meaning that they can now kind of share risk. And so, for example, if you have like 5 community health centers in an ACO, one community health center doesn't do well, they ultimately can just like share that risk a bit and just like not have one community health center kind of just like eat the cost of any downside risk. The other benefits is that, and we'll kind of see this a bit later in the talk, that resources, funds, that's really, really challenging for community health centers to adopt to value-based payments. Ideally, when you're in partnership, and I'll just kind of go to the next slide, it's like this, feeds into the next topic. Like partnerships is very much key in my view. Like for example, I'm just jumping ahead too much, but I'll do it anyway. Like data analysts are a necessary part to be able to measure kind of who are the patients you're taking care of, and ultimately just coordination, et cetera, so you can like report back data to the MCO. But community health centers may not have the funds to hire data analysts in. They may, the data analyst may be not even busy enough to, work at just one center. So if you ultimately, have a few different data analysts that are shared amongst different community health centers through an ACO, a little bit more ideal to kind of have that partnership, in my view. And so partnerships such as like with a local health system, with the MCO, with CBOs, I touched upon this in my last article about why that's so necessary to have more formalized partnership with CBOs, because they ultimately are struggling as well, because they need funds from the MCOs because there's too few CBOs to kind of care for patients' social needs. And as we very much know, like social needs are like 80% of health outcomes. And so that's a really critical thing to ensure that you have the ability to refer a patient somewhere that that they're going to get, hopefully at least, that social support. Partnership with like a state Medicaid agency, partnership between like the providers at the institution and also the community health center leadership. And we'll kind of talk about why that's particularly critical as well. And so given that you have these kind of partnerships, my view is that you have kind of these two biggest bottlenecks as well, after you kind of establish partnerships, which is technology and also workforce coordination specifically. I'll kind of go into that in a bit. And so really kind of depends on the fact, like, as we talked about earlier, it's like right now, community health centers don't have the best technology system. And as I'm sure a lot of folks know, like adding value-based care to the mix makes it even more challenging because you have to do care coordination, you have to do population health things, you have to report on things in ways that you potentially didn't have to do prior. And so having this technology is really, really critical for community health centers to be able to adopt these models, in my view. The second part is the workforce. And so like right now, like as we know, like if you go to any community health center, they are very stretched thin. PCP is, whatever staff it is, there's shortages, and then even though the staff are very kind of stretched thin, as I mentioned. And so just because you have the technology now, in my view, doesn't mean you have the clinicians to act upon those insights, or even clinicians or just workforce in general, in terms of data analysts, for example. And so that's why I think it's important to both have the technology as well as the people to actually act upon that given insights, to best coordinate and engage with patients, to ultimately ensuring you're following those kind of patients from, visit 1 to visit 2, because you want to make sure that, you understand what's happening between those visit times, and count your system. You didn't really have to, care about that as much. But in my view, from like a risk model, it's a bit more important. So I'll finish off here with another 3 slides. So my view of like potential overlapping opportunities to build in the space is about 5 things I was iterating on, just thinking about. I think like there are companies in the space. I think it's not a saturated space in my view. And so I think there's still opportunity for folks to build companies or a nonprofit. And so I still think it's valuable for folks to kind of think about this space. One is a kind of risk stratification software, kind of quality reporting software, as I mentioned, kind of knowing where, looking at things from a population health point of view. I think part of my concern is like a lack of margin. I don't really know if there's enough money for companies to capture whatever it is, in terms of like downside risk, if they can capture some of those savings. I'm not sure if it's enough money for like a a VC-backed company. I really don't know. I don't know if someone's coughing, but I don't know. I think it's just part of my concern. I think it's more of like curiosity rather than like complete utter doubt. Um, so I'd love to kind of hear your thoughts on that towards the end. I think workplace culture is also a big challenge. Like just because we're even having technology, it's like you still have to require a lot of like consulting work. You have to require like what does it mean to shift towards counter to population health, kind of whole person care, quote unquote, management. Then, as I mentioned, you have to have the workforce to ultimately act on those insights. And so I think it's like not just technology. And that's why I kind of mentioned the overlapping thing is that we've seen other companies as well add the technology plus, clinical people within their kind of care model that they're offering to community health centers. And another opportunity is like facilitating those partnerships between like the MCO or just between the other community health centers. Third one is what I touched upon in my last article, which is that social drivers of health contracts between CBOs, MCOs, community health centers, a lot of acronyms, a bit annoying, I know, but ultimately, I don't want to repeat myself too much, but I think it's really critical that CBOs get paid for their work because ultimately benefits everyone involved. It also kind of ensures that you are closing that loop. If you have the community health workers to provide to the CBOs, you have a better understanding of patients in terms of what their care, trajectory looks like. Because not just like referring them to a CBO and, for example, like a food delivery service, and maybe they never go. Perhaps they do, and you just don't know about it, and you perhaps just need better engagement. So I think it's really important to ultimately, from like a total cost of care point of view, to ensure that everyone's working together in a way that's mutually beneficial. Fourth one is taking a specific complex tech-enabled clinical service off the plate, the community health center. Fifth one is workforce training and recruitment. We've seen the fifth one, I feel like more of a nonprofit model, which I'm completely fine with. I think it's interesting potentially to expand that out a bit more. Still as a nonprofit, it might be a for-profit model as well. But we need community health workers, need better training for them, not better training in the sense like currently it's inadequate, but just more models and more opportunities for folks, and also kind of have more recruitment for people. And so that was just one example, but I'm sure there's more cases where, especially ancillary staff, quote unquote, care coordinators, et cetera, can be potentially a good opportunity for, training, in my view. Some final thoughts, then I have 2 questions on my end that might kick off some conversations. Yeah, I mean, I think value-based payments has potential to improve community health worker predictability, and the ability to enhance patient outcomes and potentially increase revenue. This is something I think Dave mentioned, which is that kind of adapted this a little bit from one of the things he said in the past. So I don't mean to misquote you, so let me know if this is not what you think. But I think we need to ensure that value-based care should remove as much admin burden as possible, deliver patient first care, meaning that things get complicated with population health and managing patients, but ultimately we need to ensure that technology is removing any barriers to ensure that care is being provided as high quality as possible. This little like saying that I was trying to iterate on, which I feel like I'm kind of there in terms of what I was wanting to articulate, but I think as things scale up, we need to kind of continue staying lean. I think that's kind of where partnerships also can be valuable, between like different community health centers where they can share resources together. So it's not just like everyone's hiring, the same staff, but ultimately you can share staff, share resources, share initial funds, because that's a really big one. It's like, it's like a chicken and the egg problem. Like, well, how do you pay for the technology? How do you pay for more clinical staff? And so like having that ability to, like having the ability to kind of have those funds is also important. Doesn't really relate to exactly what I was my last line there, but I think there's something I wanted to add. Last line though is my view. I think value-based payments is only part of the solution, not the entire solution to improve community health center stability. Particularly with like Medicaid unwinding, like a lot of patients are now uninsured, and community health centers are not getting reimbursed for their care. And like generally, their thesis is to care for as many patients as possible, regardless of their insurance status. But I think, especially in this model where value-based payments relies upon, at least from my understanding, insured patients, it's a little bit questionable whether this is kind of like, I don't think that this is like the answer to ultimately ensure that they have some more stability. I feel like there needs to be like more federal grants or just something to ensure they are also able to, have their value-based payment, but also have like additional source of income that they can rely upon. And so I think that's just generally something good that to note in my view. The last kind of slide here is questions I feel like I didn't really get to answer. Maybe because I couldn't find them, or maybe because I just thought about them today. Which is how much is shared savings from downside risk? And so, like, for example, community health center does really well in the year. Like, how much money is that? Like, where does that money go? Does that really have a big impact on margin? Does that allow for the greater number of patients who are, for example, uninsured? Does that enable community health centers to see more of those patients? Is that just like compensating providers more, which is great? But how much money is that, and where's that money go? Something I'd be interested in, which I don't feel like I addressed. I'm not sure if that information is out there, but I don't know that yet. Second one is workforce shortages. And so is workforce shortages such a bottleneck that it will not enable health centers to ultimately scale to value-based payments in the first place? And so do they have enough community health workers in the area, or do they have enough PCPs in the area? Because if you don't have the staff, you can't really engage in greater complex care models. And this is kind of like, as I mentioned, like a chicken and egg problem. If you have the initial funds, if you have the money, if you have the staff at the start, then it enables you to like build out these models more. But if you don't have that, it's hard to kind of start that conversation. So I ended it on a negative note, but on a positive note, I am optimistic about these care models in general. Would love to kind of see health centers, as I'm sure everyone agrees on this call, be successful in our country. I feel like that is a good way to end. So love to kind of hear your thoughts.
This is awesome, Evan. Thanks for setting the stage, I think, for an interesting conversation. And we do have people from actually a lot of different segments of the healthcare ecosystem. So I will call on some people who asked interesting questions. I'll actually more work backwards. Xavier, are you in a place where you can share your question that you typed out? And if it's too loud, I'll read it out.
For sure. You said starting down dinner. So I was just wondering who the interested payer would be. And this, or the question behind the question is, I talked to the Oklahoma PCA about us building out a program to create something that looks like direct primary care for community health centers. And like the first thing that they said was basically exactly what you covered in your talk, which by the way, Evan, was super great. I read the article. Thank you for writing it up. But like the first thing she said was, they may not have an interest because there's such low margins that they're like anything that's risky and so forth. Like there are all these reasons why they can't do it. They don't have the capability, they don't have the staff, all these things. And so then I'm like, okay, if it's hard for them to work with a commercial payer on it, who would be the payer who would be setting up a value-based program for a CHC, like an employer? I can only think of CMS. And even in that, it would have to be through an ACO-oriented program. Or am I missing something there?
I see.
Yeah,
Yeah.
go ahead.
I was maybe if I can call in some people. I see Pablo was shaking his head. If he can like.
Yeah, no, there are in the permanent program, it's only ACOs. In innovation center model tests, there are models where FQHCs can enter into a risk-based contract directly with CMS without reaching the 5,000 lives and without having an intermediary entity. So making care primary, that's available. I believe there's certain parts of the AHEAD model that will allow that as well.
Awesome.
Is the reason that they're not largely doing this today just the quality metrics reporting infrastructure isn't there, or is it a lack of knowledge about accessing the program, or what's stopping
Oh, I think it's the
from doing
financial
that?
risk. I think it's the financial
The risk?
Yeah.
Is there Making Care Primary has a upside only track though, right?
Track one is, I don't know that you can stay there forever. But yeah, the first track of MCP is upside down. And the first two tracks of SSP basic are upside down. But that requires an ACO and 5,000 values.
Joel, do you have anything to add from the commercial payer point of view?
See if I can get off mute except to cough. Yeah, I mean, I think a comment was made about like why, I guess, payers, right? And would it only be CMS? I wasn't really following that because, you know, payers will contract with FQHCs on value-based deals. Is there what was the reason behind that? Start with a question.
I think you're asking about my comment before of feeling apprehension from CHCs and FQHCs for doing sort of commercial deals. I don't think it was so much the impression. Sarah's the person I talked to. She's the head of the Oklahoma PCA. And this I think shows you like how ignorant I am about the situation. I really don't know. But like my attempt to do this, the reaction was, well, we can broach that topic, but there's going to be a lot of hesitation in part of many of these folks because they have sort of bigger fish to fry. They're too busy putting out fires. Many of them don't have the infrastructure to report on any of this stuff. They don't have the capacity to take on any new programs. They just want the better fee-for-service rates if they can. And ideally, they'd like to get more uninsured lives insured, which is sort of a separate question.
Right. Okay. I mean, yeah, I mean, I think I can just share that. Yes. I mean, I work for multiple payers, and generally they'll do baby steps with value-based and FQs, mostly focused on the Medicaid population, because most health centers, I know I need to stop saying FQH, but I just can't help myself. You know, but it's generally focused on the Medicaid side, and you know, we'll do. I think the most basic thing you'll see is just like simple paper, quality paper reporting type thing. I even see simpler than that, which is like, we'll pay you an extra dollar amount for every gap you close, which I don't even think of that as value-based, but I do see a lot of that. Payers like mine at Aetna, and I've seen it elsewhere, will start to dabble into, you know, potentially shared savings arrangements with FQs. If they're large enough, you know, they have enough of a membership population. You know, my plan, we're kind of changing the bar a little bit and saying up to 1,000 members. Like if they have at least 1,000, I'm willing to do shared savings. And then, you know, I think when it gets into risk, any kind of risk, I think the challenge is state policy issues. You know, PPS, like or it's the PCA, right? They're too nervous about protecting PPS or getting PPS to a certain place where they feel like it's the right level before you start negotiating what is like capitation going to look like on a 3-year look back, right? Which is like what I know the Making Care Primary, the MCP program, you know, starting to do and looking at, I think, 3 years of history, right? So it just gets challenging to get to risk with them, but you know, it's something I'm motivated to solve for.
Thank you. That was great. Bryce, you put out a lot of interesting questions in the chat. I think if we can start with the one that you, if you don't mind saying the question out loud about standardizing data for reporting.
Yeah, Evan, do you know anything about if the CHEs could or have standardized their value-based payment contracts? For example, you have your normal parameters, and they just enter in the intensity of that parameter, like the A1C cutoff or whatever that counts as making their measures. So essentially having a contract where they've standardized the pieces of the contract and the data fields they need to track that, and that way it makes it easier for people who want to contract with them instead of everything's bespoke.
No, that's a great question. I feel like I probably could make a decent guess on it, but I'd love to kind of throw it back to anyone else if they have a more kind of concrete answer on that. Great question, Bryce.
I mean, take a guess, Evan, if you want us, even if it's not correct, whatever, because you've got the data background. I'm curious what you're thinking.
That's the post the wrong answer on Reddit, and then the commenters will correct you if it's wrong
But I
method.
don't want to be, you do that. You do that. Then. You're the person that's gonna be wrong and correct it. No, I mean, is there a way to standardize? Like data fields? I mean,
But my question was more, are they currently, like it's definitely possible probably other healthcare fields, but definitely other sectors have already done it. It's just I didn't know if CHCs had done that or thought about it, I guess.
yeah, I don't feel like I got a good answer to that. I feel like data is just so unstructured that it might not be as easy just to like pull data and just like understand the kind of patient population you have. That would just that would be like my knee-jerk reaction, but it's a great question.
Yeah, and this is Joel again. So I want to make sure I understand. Are you talking about standardizing data exchange between CMS or payers, or are you talking about they dictate which metrics and benchmarks or targets or performance in a standard BBP deal with a payer?
More that they just have the parameters for what to track. So
Oh, I see.
so there's lots of ways you could track these things, but when you, like I said, you can create the field and then you have like the number options, the options within those fields that are acceptable or normal or standardized. And so they could say, yes, we do value-based payments with payers. Here's our standard contract we do, and then the payers are going to want to choose their own stuff, but it will be within those within those fields. They can choose the parameters. Like here's where the cutoff is for A1C. Here's the cutoff is for cholesterol, whatever else.
So when
That
when you say
that's more about it.
parameters, I think you mean like performance targets. So like,
Yeah, that could be, yeah.
Okay. Yeah. And so my answer to that is I don't think health centers have I guess like a lever or whatnot to be the one to dictate that. It's unfortunately usually the payers, including CMS themselves, as a payer, that builds models and frameworks. Right. Again, I'll go back to making care primary that's being piloted in 8 states, right? Like CMS and the Innovation Center and all that, they designed that. And obviously got public input and all that, but that's their framework, and they set the benchmarks. I believe they're using like MIPS instead of NCQA. And then and the same thing with the payers, right? The payers will make their framework, their model, and they'll go to the health center and they'll say, hey, this is what I got, and are you interested? And I don't really see that they have negotiating power or leverage to influence that, which I think is also why we see such a rise in value-based aggregators like Aledade and all the other ones, because they're just tired of 12 different health plans having 12 different models and benchmarks, targets, and how they earn money and calculate. They'd rather just have one person aggregate it all and give them one thing.
Makes sense. It's very interesting.
Yeah, this is interesting to hear for sure. Now, Dave, you had a question about, was it about scaling? Do you want to ask that one?
Yeah, so one of my questions that I'm just adding to your negative ending slide, Evan, is if value-based care models scale into resource scarce areas of care. And what I mean by that is, does contracting for downstream metrics work as the provider being one of those sticking points, or is this such a resource desert in some of the Medicaid spaces or the FQ spaces that even if you're doing this value for the downstream benefits, there's just not really downstream benefits to capture because there's so many other disparities that are there that need resources. So is this like a beneficial exercise for everyone involved in this space, or is this like a resource desert that's not the one resource that's things aren't growing, so to speak?
That's really interesting. Like a rural health, like more like rural health, where like they just don't have enough providers and things like that.
Well, I guess like my point is like if you're trying to capture downstream benefit of improved healthcare, but the
Yeah.
problem is housing, food, transportation, jobs, right? In an area, healthcare might not be able to capture downstream benefit for more investment if that's not the main driver of disease or other value items. So maybe this is really about aligning what the capture is for what healthcare has effect over to change in resource deprived areas.
More like CBOs and like social resources, like food and housing and things like that.
Mm-hmm. Because I guess if the clinic is responsible for downstream effects that are driven by socioeconomic drivers, and
Yeah.
they don't have any levers to pull on to change those, then you're just like setting up everyone to fail in the value market. I don't know if
No,
anyone else has comments on that space or thoughts on that.
no, it's a great point. My last article was kind of pretty much on those. So yeah, I mean, I think it's definitely yeah, I mean, I think it's definitely like an underrated thing. Like that's why at least my thought process is, to kind of develop these partnerships prior to like doing these care models. Because as you kind of mentioned, if you don't have, if you're trying to manage patients on diabetes and you don't have food, you can kind of give them that is aligns with what they need to eat. Then it's just not going to work, as you're alluding to. And so I do think that, I mean, it's just like another barrier, another big challenge, especially when you, as you kind of mentioned, like you don't have enough CBOs in the area. And so I do think that like having those contracts, and Joel may or may not agree with this, and love to kind of hear his thoughts, to allow the MCO to pay for those CBO services, ideally allows for patients to kind of address those social drivers of health. And if it decreases the total cost of care under these kind of value-based care models, then ideally it's a win-win for everyone. But it's definitely like another layer of complexity that is a very good kind of call out. So I appreciate that.
No, and this is Joel. Yeah, I mean, yeah, we will pay for additional resources at times. And again, I've been geeking out on the MCP things. You're gonna hear me say that like every time I talk. But that has a payment model from CMS that's guaranteeing funds to FQHCs or health centers that is specifically to hire SDOH type people, CHCs, CHWs, or not CHCs, CHWs, care coordinators, those kind of staff, and they're putting a PMPM on that as additional revenue for the health centers. And the health plan model, I don't think we've gone quite as far as the dollars I'm saying there, but we've definitely been willing to give, not a lot. I've seen $5, $10 more just for like, hey, here's a care coordination fee to help you, fund and hire those types of people to do that kind of work. We also do like delegated care management type fees sometimes, or just pay for case management for complex populations and say, here's funding monthly for a population of really sick and really expensive people, so you can hire special staff to better manage that population. So we'll do stuff like that. I wouldn't necessarily call it value-based though, because it's not tied to metrics or performance. And CMS kind of dropped a hammer recently with the final rule, the new mega rule, that redefines value-based payment models as being something tied to quality or clinical performance metrics, right? So, so it has to be outcomes based, right? You can't just call it value based if there's no performance metrics. But still, we can do funding like that we think makes sense to fund for staffing models that are dealing especially with complex populations.
Joel, on that note, is it usually 50% roughly of the salaries of those staff, or is it full 100% comp? And the length of contract, are those usually 1 year only, or they go indefinitely? I usually see them start for 1 year and then maybe 2, then it goes away.
Well, it's interesting. I haven't actually done one with a health center yet because I haven't seen a health center who wants to or even probably could do that yet. And that's just in my state here, and then coming from California, that's full of the IPA models that were referenced earlier, so it's just different, but maybe in other states. But yeah, it depends, right? I have point solutions where I've hired some organizations like, actually I can't name names, but there's high PMPMs involved sometimes, as long as it's dedicated to Aetna's members, let's say, as one health plan, right? So we'll consider a significant, PMPM in the hundreds of dollars for 1,000, 2,000 complex patients that some organization, that has doctors, nurses, BH staff, and someone's going to wrap around, visit them in the home, do some more high touch care for them, we will pay for that.
You and I were supposed to chat a long time ago, so I'd love to have a conversation again in the future about that. We have a large facility called Ultimed in California, 500,000 patients that we're about to contract with in the next few
I know
months.
all about Ultimed,
So
the big,
let me know. We can talk about that
the
later.
big daddy of health centers,
They are
and
the
they're
number
on
one.
IPA.
Yeah, they're a very amazing group, but they're highly complex. It's strange to say they're a multi-billion-dollar nonprofit in the same sentence.
I know, it's
But
amazing.
they're crazy. So we'll talk about that guys later. But I think on this note, on the quality side, so we work with right now 6 different health systems, all FQHCs in 5 different states. And number one challenge for them obviously is staffing issues. And predominantly, especially with the 330 grant program. So they're subsidized by Medicare, Medicaid, other plans as well, like you said, as well as the grant side of things. And we'll see under UDS, we'll look at their metrics for year over year, and you'll see spikes in different, like for example, we're in the cancer screening space, and you'll see a spike for colorectal, from 16% maybe up to 30 for 2 years. That grant goes away, and then it goes right back down to 16% again because they can't hire the staff to manage it. And example of this is a facility out in Oklahoma, rural Oklahoma, the largest rural system with 35,000 patients. We just hired our first nurse practitioner at that facility, and she's starting July 12th. So we have 35,000 patients, about 6,000 are eligible for lung cancer screening, which is our bread and butter to start with. But they have a backlog of 15,000 patients for breast, colorectal, and cervical, which are the 3 mandated measures today under the UDS protocol. And unfortunately, good or bad, lung is becoming the 4th measure within the next 2 years. And there's 6 other RADs, other radiological programs that will be building into that. So there'll be 10 different protocols they have to manage, not just 3. So they're already underwater with 3 by 15,000 patients, actually 20. And now they have to do even more. So that's kind of the problem that most of these facilities are facing. The larger ones, still a problem, but they just have more money to throw at it, meaning more staffing. But it doesn't mean they're doing any better because they have technology issues. They're not using AI yet. So AI will make a huge impact, but people are still scared to buy it. So AI assurance is the new coin term that a lot of people are throwing around. Basically, it's quality assurance. And no one's really understanding how to purchase AI, let alone use it. And so companies that are building AI predominantly without any clinical component are struggling to sell it. And it's specifically in the radiology space, but it can go other areas as well, like navigation, other solutions. So, but if you guys have any questions about that stuff, we can definitely nerd out about it later.
There was actually a related question from Fawaz. I don't know if you're around. Nice.
I'm here. Nice.
Uh,
Yeah, it's this fancy organization that these 3 docs run.
You had a question about investment in technology. Do you want to ask it?
Yeah, I think I put the technology literacy question afterwards. It actually should have come before. I see this a lot on the engineering and product side. So we're an internal team to Elevance, and we sell to Elevance health plans, right? And oftentimes, unless you have, a unicorn who understands technology, the business really doesn't understand what things cost. And, they're ripe to be taken advantage of even by internal teams. And without technology literacy, I think FQs, would be, they'll struggle to find the right fit. Also, maybe they have some idea or no idea of what's out there in terms of analytics tools and whatnot. So that, to me, going around and shopping for a tool might be a struggle. That's one. And then given the price tag, I think without a for-profit incentive there, the ROI, I don't know how willing will they be to invest in something like that, and saying, maybe 3 years down the line, we'll have a downside risk relationship with a large payer or CMS and then make our money back. So to me, that seems like a, long ask for health centers. I might be wrong, but that's, a question, but also an opinion. I don't know if anyone wants to take that.
Evan, you had a comment there actually in chat.
Yeah, I mean, there's a lot of kind of interesting questions there. I'll kind of say my thoughts. Will also love to kind of hear what other people have to offer. Yeah, I mean, I think with regards to the initial funds thing, I think that's a huge challenge. I put like a quote there that's also in my article for folks to check out who aren't on the Zoom chat. That kind of mentions this exact challenge that you don't have the initial funds to ultimately pay for these things, and I like don't think community health centers don't have that funds just to like pay for technology. I think we've seen that a bit within the 1115 waiver that can not pay for the value-based care technology per se, but just generally, I think in Massachusetts, they did do that. Like they formed an ACO called C3, I believe. I believe that that's like this, what I'm referencing, but I think they use the funds from 1115 to pay for technology, including community health workers and just the paying for CBO services, I believe. I know they're doing that in New York and North Carolina and California, so I'm not exactly sure on the specific details of the MA one. Hopefully that addresses the initial funds thing. I think it's a big challenge. I think like that's like a big part of what I was trying to wrap my head around, and so I really appreciate that one. I guess the other question was on more of like, is it even a good enough ROI for community health centers like to take the risk to do it in the first place? Was that kind of the last question?
Yeah, I mean, I don't know how big health centers are, but usually there's inertia from leadership on a big investment, right? And someone might say, oh, you know, should we invest now? And then how do you choose a vendor? I mean, lots of questions there. These are just practical kind of day-to-day discussions that happen. And I think that health centers maybe are not sophisticated enough to make those decisions yet, or are they? Maybe change my mind, Evan.
I mean, my feeling is that it probably comes through a lot of like connections and just like if the state community health center agency has that knowledge to pass upon to the other centers, and so I think that could be helpful. Yeah, so that's kind of my
The integrated clinical network that I read that in the article. Yeah,
that's another option. Yeah, so I think yeah, I mean, I think you're also getting at like more of a greater challenge. Joel, did you have something to say? I see your screen there.
Yeah, I mean, when you said the PCA, right, or the Primary Care Association, like in Virginia, they're also, I forgot what the acronym stands for. Is that what you meant, like clinically networked? Like what's HCCN? I know that's something that they are, but they're offering, that kind of technical know-how and support to all the 27 or so member health centers in the state, and they've built, a central repository, a database that plugs into all of their EMRs. They're also trying to get them all to actually, they did successfully get all of them once upon a time to standardize on eClinicalWorks, and now they're trying to upgrade them to Epic. And it's that kind of stuff. I agree. Like, I don't think individual health centers are large enough, don't have enough funding, or even know-how to accomplish that on their own. But when they have a strong PCA or any kind of organization, whether it's an ACO or an IPA or something, right, to help do the investments and guide them, well, then I think something can happen magical, right? And so that's what's happening here. They have a central database that gets the payers more interested too, because now, comes a little bit easier to do some kind of, I don't know, some kind of value-based arrangement where it's easier to get the data from one source instead of having to go to 28 health centers, right? And I think that just opens up a lot of possibilities.
Yeah,
I'll add some of those PCAs are more sophisticated than the more suburban oriented conveners. Like they're doing some pretty advanced things. C3 is doing a whole lot of stuff, and they're, as I understand it, they're FQHC owned and FQHC managed, so there's not the same kind of dynamics that you have in other of those conveners. I don't think any center could do it alone, but I don't think any like small group practice could do it. you have to get some economy of scale, and you've got to get some expertise, whether that's through an MSO or an enabler, or you know, making a big investment and bringing all that in house. But definitely, like, you know, the size of health centers, most health centers, and you know, you're kind of 4 to 6 doc practice. That's just, you don't have the scale to do this stuff.
Exactly. Yeah.
And that was one of the takeaways from our meeting in Philly in April, was that startups who wanted to engage with FQs were really redirected to engage with state level organizations, because that's where, you know, and startups are often misguided to go to the source. And they, anyway, that was an interesting lesson, I think, for everybody. So good to see that you guys are nodding with this. I am going to pause the recording.